It's important to recognize what are the kinds of iron deficiency which happen in heart failure. It can be put into two broad buckets. One is absolute iron deficiency, and the other one would be functional iron deficiency. In terms of absolute iron deficiency, it reflects reduced iron stores. This is due to malnutrition in patients with heart failure, especially advanced heart failure patients. Also from malabsorption, from mucosal edema or gut edema, use of concomitant polypharmacy such as PPIs. It also is from reduced iron transport across the duodenum, which we'll be looking at a little more in detail. And then also from GI blood losses, both microhemorrhages and macrohemorrhage, from gastritis, medications which cause hemorrhage, as well as loss of mucosal integrity, and then quite often from blood sampling itself, from frequent blood draws too. But what is more unique about iron deficiency in heart failure is the functional iron deficiency, which is as a result of the inflammatory state where there's a uptick in cytokines. And then this results in blunted response to erythropoietin, apoptosis of the progenitor cells, and then more importantly, hepcidin-mediated malabsorption and pooling of iron stores in reticular endothelial system organs. This is a slide in more detail on functional iron deficiency, and it's important to recognize the mechanism behind it, because that obviously has an impact on how we replete iron stores and some of the shortcomings in some of the previous trials as well. In functional iron deficiency, the mechanism is a generalized inflammatory state in heart failure with increased levels of pro-inflammatory cytokines such as interleukins and TNF-alpha, which results in increased production of hepcidin from liver, which is an acute phase protein. Hepcidin actually regulates the release of stored iron from both hepatocytes and also absorption across the enterocytes. And it negatively affects the transport protein called ferroportin, and it causes this degradation, resulting in decreased transportation. And also it promotes sequestration of iron in reticular endothelial systems such as spleen and liver and bone marrow, resulting in functional iron deficiency. This slide actually shows you sequential changes in iron deficiency anemia, and this is important because if we go by traditional indices of anemia such as hemoglobin and hematocrit and MCV, you can see, or you can appreciate on the lower side, that they do not get affected until full-blown iron deficiency anemia kicks in. However, early in the state, in the inflammatory state, when there's depletion of iron stores, there's a reduction in ferritin. And that is followed by reduction in iron saturation in more moderate states of iron deficiency. And at the end, when it's, again, as I mentioned earlier, iron deficiency anemia, reduction in hemoglobin and hematocrit. So it's important to recognize that ferritin needs to be looked at early on if we are suspicious of iron deficiency anemia in these heart failure patients. This is, again, another look at the different levels of different iron measures or indices in different types of iron deficiency, both functional as well as absolute. If you look at normal levels, people with normal iron stores, serum ferritin is usually more than 100, serum iron is more than 50 micrograms per deciliter, and transferrin saturation is more than 20%. As functional iron deficiency kicks in, the serum ferritin may still be more than 100, and the serum iron is less than 50, and transferrin saturation is less than 20. However, in absolute iron deficiency, all the stores are depleted. You have reduction in serum ferritin, serum iron, as well as transferrin saturation. And this is important to recognize these different variations and changes to correctly interpret iron deficiency in heart failure.